Hello everybody, and welcome to today's Revive webinar by the Global Antibiotic Research and Development Partnership, GARD-P. My name is Astrid Pence-Moore, and I'm hosting this webinar on inhaled antimicrobials. In 2018, GARD-P has launched the education and outreach program Revive with the aim to connect and support the antimicrobial R&D community, facilitating learning, sharing knowledge, and connecting people. These webinars are part of our educational activities. All webinars are recorded and can be viewed after the live broadcast on our website, revive.gardp.org/webinars. I encourage you all to visit the Revive website to stay up to date about future webinars, watch recordings of previous webinars, and also to find other information. Please note that today's webinar includes patient videos. Whilst these patients have kindly consented to today's broadcast, it must not be copied or recorded in any form. A redacted copy of the presentation, excluding these videos, will be made available after the presentation. As always, today's presentation will be followed by a Q&A session. You can submit your questions at any time during the webinar via the questions window in your webinar control panel. We will address the questions after our presentation, and we will do our best to respond to as many questions as possible. Please note that today, for the first time, we will use webcams of the speaker and the moderator during the presentation. I would also ask our speaker and moderator to put their webcams back on when it's their turn to talk. I just switched them off now for the introduction. If you in the audience experience any issues due to limited bandwidth, please let us know via the questions window. In case several people inform us about bandwidth problems, we would continue the presentation without webcams after all. Today's speaker is Harm Tiddens, and our moderator is Harpal Singh Dhillon. Welcome, Harm and Harpal. Harpal, I'm now handing over to you for the introduction.
Thank you, Astrid. I'm now happy to welcome Harm. Harm Tiddens holds the position of Professor in Pediatric Pulmonology at the Department of Pediatric Respiratory Medicine at the Erasmus Medical Center. He is the Director of Cystic Fibrosis Research as well at Erasmus. Harm did his PhD studying structure and function of chronically inflamed human airways. His research has been focused ever since on this topic. In addition, he has conducted many studies on the relationship between the lung structure and function and the deposition of inhaled aerosols. He has held an honorary position with the Department of Radiology since 2007 and is a visiting professor at the General Hospital Ningxia Medical University. Harm is an editorial board member for the Pediatric Pulmonology and is a regular reviewer for major respiratory journals and various international funding bodies. He was co-founder and member of the Executive Committee of the European CF Society Clinical Trial Network and has been a board member of the ECFS until 2019. He founded and is heading the Erasmus MC Lung Imaging Group at the Lung Analysis Core Laboratory, which focuses on the development of CT and MRI and image analysis techniques to monitor chronic lung disease such as CF, bronchiectasis, primary ciliary dyskinesia, bronchopulmonary dysplasia, and congenital lung abnormalities. The Lung Analysis Core Laboratory has been involved today in over 40 international studies. Harm, it's great to have you today, and I'm really looking forward to the presentation. Over to you.
Thank you very much, Harpal, for this introduction. So good morning, good afternoon, good evening, good night to you all, because I learned that people are connecting to this webinar at a global level. Today I want to discuss inhaled antibiotics. Do we get the drug to the bug? As a disclaimer, I'm a professor in pediatric pulmonology, pulmonologist, but I'm not a microbiologist. But I work with of course, antibiotics, and especially interested in how we can make the delivery through aerosols more efficient for our patients. And I have to click for the first time on my slide to see the control panel. And it's not working. It is. So first of all, my conflicts of interests, there are many, so you have to be very critical to what I'm saying. Most of what I do generates money that is going back into my research. I want to start off with acknowledging my research group, which is quite a unique collaboration between the Pediatric Pulmonology group, the Radiology department, and the Computer Science department, where the people are located who can translate images into numbers that count, that we use in our research. And we do our research with a couple of cohorts, like the Generation R cohort, which is a healthy birth cohort, bronchopulmonary dysplasia, congenital lung abnormalities, etc., etc. So I'm going to set up my presentation. I'm going to discuss the following subjects with you. I'm first going to discuss some key features of the lung. Next, I'm going to discuss imaging, which plays an important role in my research, and hopefully for you will help to understand the issues I try to discuss. Next, I'm going to discuss some basics of aerosol science. Then we move to some modeling studies that we did. Then we should not forget what the patient is doing at home. I'm going to discuss that. And finally, I'm going to discuss if we get the aerosol to the site of action, is that the whole story, or are there many variables which still can impact on the efficacy of the inhaled antibiotic? So let's now move first to the basics of the lung. So the lung is a complex organ. Of course, any organ in the human body is complex, and the lung is no exception. The number of breaths throughout your life is about 1.2 billion times. And every day you inhale around 30,000 liters of air, with all that comes to it. You inhale bacteria, viruses, and pollutants. And the lung is very efficient in protecting itself, in filtering out what you inhale to avoid, of course, infection and damage. So the number of alveoli, you have about 8 million, and there's an impressive number of airways, 260,000. But what number you should remember in relation to my presentation is the total surface area by the airways, which is in the order of 12 square meters. And that is what we try to cover with our inhaled antibiotic. If you even want to target the alveoli, the surface area is even much bigger. It's about 74 square meters. That's a tennis field. The inside world is protected from the outside world by a layer which is only 0.3 micron thick, which explains why the lung has to be very efficient to keep out the microorganisms especially. So the first question, if you talk about inhaled antibiotics, is where do you want the drug? And of course, you want to have the drug where you think the bug is located. And it can be the large airways, that can be the small airways, it can be the parenchyma, it can be in the mucus, the airway wall, or in consolidations. As part of my PhD work, I investigated the structural abnormalities in cystic fibrosis. So what you see here is a cartoon which just explained the total cross-sectional area of the airways. So over here is on your right side is the diameter depicted of your trachea. So this is what you can feel in your neck. If you move to the periphery of the lung, you have to realize that the total cross-sectional area is increasing tremendously, as what I already alluded to, you have an enormous number of airways. So investigating this at the time, I compared the airway dimensions of CF airways to those of COPD patients who were operated. And even though our comparator was not in a healthy population, the peripheral airways, they showed a threefold thickening relative to the smoker's lung. So the most structural abnormalities are located in the small airways, and the same is true for actually COPD patients. So where are the bacteria? Actually, for Haemophilus influenzae, and these are old publications, but I couldn't find any more recent, but it's located throughout the airways. For Pseudomonas, there are old publication, 1989, which shows that Pseudomonas is especially located in the small airways, and it makes sense because that's also the place where you find the most morphological changes. So let's now move to the imaging part. These are actually, is a CT scan of my lungs. And here I take a full inspiration, and on the right side, a full expiration. And as I know what I had to do, you can see I did a good job. If you look at the pleura between the ribs, you see that's even bulging out. So I'm really maximizing the space for my lungs. The orientation of the airways is vertical. So these are the dimensions of my inspiration, and now I project them over the expiratory scan. And you see the lung tissue has become much more dense, and the most movement has taken place by the diaphragm, which behaves like a kind of cylinder. That's how air moves in and out. So the lung is like a bellows, and it moves air in and out. And you see that on expiration, this density is nicely homogeneous. And that means all over my lung tissue is quite healthy. This expiratory scan is quite important, and I'm going to show you in the next slide why. But first, I want to show you how we standardize our chest CT. Because that is, in many centers, that is still not done routinely, but it gives you, if you do it, it adds a lot to the information given by the scan. So it's not rocket science. We just train our patient. This is the lung function technician. She trains the patient 30 minutes before the scan. And so the patient knows exactly what breathing maneuvers are requested in the CT scanner. So tidal volume breathing, breathe out, and now all the way in, hold your breath. And this is the time when we scan. So you scan during a breath hold and don't have movement artifacts. Then you can move out, let it go. For the expiratory scan, tidal volume breathing, breathe in, take a breath in, and now out, all the way out. Hold your breath, hold your breath, hold your breath. Thank you. And then you have an expiratory scan at residual volume. And in our clinical routine, this procedure is successful in 90%, and it has added a lot to the diagnostic value of our CT scans. So why I'm telling you this? Because I want to show you on this slide that actually the expiratory scan shows that large chunks of the lung can be involved, and you just can't see it on an inspiratory scan. So cystic fibrosis, left upper panel, you see inspiratory scan, there's some bronchiectasis, but overall the parenchyma looks quite healthy. But if you look at the expiratory scan, you see all those dark regions. And those dark regions is often defined by the radiologists as trapped air, but in reality, it is a combination of probably a lung which cannot deflate totally, so trapped air, combined with hyperperfusion. And you see that the volume fraction of those dark regions occupies about, I would say, 40 to 50% of the lungs. So 40 to 50% of the lung is not healthy. There is something going on, and probably this is related to infection in the cystic fibrosis. Bronchiolitis obliterans, this is a patient who went through adenovirus infection, and on expiration, though you don't see it on inspiratory as well, you can see it on a good monitor, but on expiratory or expiration scan, you see there's a large chunk of the right lung, which is very dark, so defined as trapped air, but again, it represents an area of hyperperfusion and trapped air. Influenza B, this was a patient admitted to the intensive care. This is in the follow-up. And you see there again, there is about 40% of the lung showing this severe abnormalities. So I'm actually, in this time of COVID-19, I'm very curious to see in the follow-up of all our COVID patients. I would guess that there are many patients who can show a similar expiratory scan like this, making clear that even though the lung on inspiration might look normal again, it is still dysfunctional for large parts of the parenchyma. Bronchopulmonary dysplasia, it shows the same thing. On expiration, you see large chunks of the lung which just don't deflate. Here in an asthmatic patient, you see the same thing, congenital emphysema. So what I show with this slide is that the expiratory scan gives us a good idea on the severity of the patient I'm dealing with that I try to treat. And we have to personalize our treatment. And this is actually before a patient comes in my outpatient clinic. I always look at the CT scan to have an understanding of the kind of tissue I try to treat. This standardization we have now implemented in many studies worldwide. And just to mention a couple of studies which are relevant and which are focused on antibiotics is the format study, where we use chest CT scan to phenotype the patient, but also as outcome measure. And the lung analysis lab is standardizing chest CT and analyzing it. And this is a study which is focused on the treatment of Mycobacterium abscessus. Another study that we're involved in is the CASPER-CF study, which is a study looking into the treatment of Aspergillus in cystic fibrosis using posaconazole. Another study that we're involved in is the COMBAT-CF, which is the randomized controlled trial using azithromycin in young CF patients. So in antibiotic study, chest CT is involved. So another way to image the lung, and which can give us, I think, important information in relation to inhalation of antibiotics is the magnetic resonance imaging. Some people consider MR like and CT like an apple and pear discussion, but MR is more like jackfruit. It's quite exotic for the lungs, quite an exotic diagnostic instrument. So just show you the CT scan of an apple, and you see very nice morphological details like what I just showed you also for the lungs. If you look for MR, MR is powerful to differentiate between different tissue components. And that is highly relevant for the lung, because if you want to study to differentiate the airway wall from mucus, for example, MR can show that, and on CT you will not see it. So I'm now going to show you the hazardous route that the aerosol, inhaled aerosol particles have to overcome to make it all the way to the lungs. And the first important structure they have to bypass is the nose, which is a very efficient filter. And then the next hurdle is the glottic area. And over here you see with MR with great resolution of 0.6 millimeter, you can see the vocal cords, arytenoids. But what is important is this actually is a very small space that is left open when you inhale. And that is creating turbulence. So during inhalation, much of the drug will actually end up in the subglottic region, which is again a very narrow part of your respiratory tract when you discuss inhalation of aerosols. So just to show you that, of course, you have patients who have even damage of that region. And this is a patient, an ex-premature child who had tube damage, had corrective surgery, and at the age of 11 years still had a hoarse voice and restricted spirometry flows. And a static MR image shows you abnormal position of the vocal cords, and the dynamic images, and here the patient is asked to phonate, to speak, to say ah, and you see actually that the patient can't close the vocal cords. And you see it's also very asymmetrical, because actually this patient doesn't talk using vocal cords, but using the false vocal cords. And some patients have a fixed obstruction at this level, and which makes it even more challenging to get aerosol to bypass these kind of restricted regions. So the next hurdle is actually the trachea, which is still a narrow section of the airways. And often you have, especially if you inhale forcefully, you have turbulent airflow. And there are patients, of course, who have also an abnormal structure of the trachea. And this is, for example, a patient who has a malacia, which means on expiration, there is actually a substantial reduction of the diameter of the airway. And over here, this reduction is more than 50%, which means if this patient inhale an aerosol and then exhales, then there will be substantial deposition of the exhaled aerosol, which has not been deposited in the lungs, and it will be deposited at this site of obstruction. So the next station is the parenchyma. And on your left panel, you see the dynamic images of a CF patient with well-preserved lung structure, except there's some bronchiectasis of the right upper lobe. And what you can see on inspiration, this patient is asked to take a deep breath in and a deep breath out. You see actually the parenchyma nicely follows the diaphragm. It's nicely symmetrical on the left and the right side. So air is going everywhere. This is a patient of a similar age with end-stage lung disease. And this patient also is asked to take a deep breath in. And now you see that actually only the lower areas of the lung show some expansion. And the more diseased upper lobes, which show mucus impactions inside the bronchiectatic airways, hardly show any change of volume, which means if this patient inhales, the drug will go nicely everywhere throughout the lungs, while if this patient inhales, drug will only go to the lower lobes of the lungs. At least that is what we thought at the time when we made those images. So this is another example. This is work that we did in Yinchuan in China, comparing the dynamic movement of the lung of a healthy volunteer on the left side. And you see that actually, again, there's this thorax is increasing in anterior posterior position, and the diaphragm is lowering nicely, and the parenchyma is falling. On the right side, you see a patient with chronic obstructive pulmonary disease, smoker lungs, and with severe emphysema of the lower lobe. And again, this upper lobe, maybe there is still some change in volume of the parenchyma, but in the lower lobe, there's no change in volume, which means if you treat such a patient with an inhaled antibiotic, no drug will go into the lower lobe. So let's now move to the what this all means for aerosols and your inhaled antibiotics. So I always explain in this way. So you see here on the left side, you see systematically central airways, so trachea, right main stem bronchus, left main stem bronchus. It's like a highway, and there is fast driving on the highway. The big inhaled particles you can compare them to a truck, and they have to make a curve over here. The truck, which has a lot of mass, has a high probability of ending up against the wall, against the guardrail in case of the truck. Now, the smaller particle, let's say for the comparison with the highway, let's say this is a Volkswagen Golf. That car, because it's smaller, has less mass, can easily follow the stream, make the curve, and make it down there to the smaller roads. This smaller particle even goes with the flow and has no probability. So this is like a smart car. In children, the road is more narrow. It's more like an English country road. And the driving is faster. The flows are higher in the airways of a child. So now also the middle-sized particle has a higher probability of ending up against the guardrail. And only the smaller particles are able to follow the flow all the way to the smaller airways. But now on the right side, we don't discuss the treatment of healthy airway. We talk about the treatment of diseased airways, bronchitis, pneumonia, etc. So there is mucus inside those airways of causing turbulence, and turbulence means there's a high probability of particles ending up against the mucosa and getting deposited there. And they are more narrow, those airways, thanks to mucosal swelling. So it is quite a challenge actually to bypass these central airways in the diseased lung. So this is another way of looking at it. If you have a healthy subject and this healthy subject is inhaling from a nebulizer while tidal volume breathing, quiet breathing, you get most of the aerosol which will end up in the central airways and very little will end up in the alveoli. If you now ask a healthy subject to take a slow and deep inhalation, you have a high probability that also the larger particle will follow the slow airstream all the way up to the small airways. And the right lung and the left lung, there will be equal distribution of the inhaled aerosol. But now, in the case of the diseased lung, you will have an obstruction, which means this segment of the lung will be slower in opening up, and there is resistance, so there will be turbulence over here. So actually, most of the aerosol will go into your well-preserved and normal behaving lung, and little of the aerosol will go into diseased areas. So just to illustrate this a little bit better, I'm going to show you hyperpolarized helium images of an asthmatic patient who was inhaling the gas, which gives a contrast in the MR scanner. So you can see actually the distribution of the air very well. And this patient inhales before he gets a bronchodilator and after he gets a bronchodilator. So first I show you the inhalation of the hyperpolarized gas before the bronchodilator. And so this is a color map. So you see in red, and I will show it again, you'll see high density of the gas central airways, and you will see a high density of the gas in the upper lobes. But very little of the gas is actually ending up in the lower regions of the lung. So now the patient ends up, I just show it one more time without talking. Okay. So now the patient takes a bronchodilator, opening up obstructed airways, and inhales again the gas. So you don't have to be an expert to understand there's much more higher signal intensity in the upper lobes, and there's also now signal intensity in the lower lobes. So the distribution of what you inhale depends heavily on the patency of the airways. So this is basically the most important take-home message from my presentation, that you have to keep in mind when you talk about the aerosolization of antibiotics. Think about, you have to be aware of the condition of the lungs. Healthy lungs, you get homogeneous deposition. If there is a severe disease, they will have inequality in homogeneous deposition, and the more diseased areas will get less drug. Patients don't only inhale from nebulizers, antibiotics. Nowadays, they're also dry powder inhalers. And this was actually from our patient magazine for cystic fibrosis. And we interviewed one of our patients about the inhalation of tobramycin inhalation powder, what she thought of it. She said, well, you know, it's great because it's easy to carry around in my handbag. It's fast, it's easy to clean, and I can store it at room temperature and go on holidays without any problems. The only disadvantage that she measured was it can cause cough. So what about this dry powder inhalers as a modality to inhale your antibiotic? How does it compare to a nebulizer? And this was actually the study comparing the efficacy of inhaled tobramycin in cystic fibrosis administered through tobramycin inhalation powder versus tobramycin inhalation solution. And it was a comparative study, non-inferiority study open label, where patients were randomized to one of the two, to tip or to TIS. So first go to the upper panel. You see the FEV1, and patients had 3 cycles, each 1 month. So they inhaled the tip or the TIS for 1 month, and you see what it did on here on the FEV1, how much air you can squeeze out in 1 second out of your lungs. So on the antibiotic, it improved. Then they were off the drug for a month, it worsened again your FEV1. Then they were on the drug, it improved, worsened, improved, worsens. And as you can see, there was in dotted line here is the inhalation solution, the gold standard, and the solid line is the inhalation powder, and you see actually the pattern is quite similar. The bottom panel actually shows you the colony forming units. So the patients had to give up sputum, and the colony forming units were counted. And what you see that on the when they were on the tobramycin inhalation, there was a 2 lockstep reduction in sputum density. When they were off the drug, it increased off, on, off, on. And again, the pattern is similar, and there was no significant difference. So actually, in the article and also by regulatory, it was considered that they were equal. There was one remarkable finding in that study that puzzled me. That was, if you look at sputum concentrations in the tobramycin inhalation powder, the concentration was double relative to tobramycin inhalation solution. So that made me wonder about what that meant. And because I was involved in at an early stage in the development of the dry powder inhaler when it was still in the hands of the company called Pathogenesis. And we executed on their request a study where we looked at what CF patients, how they can inhale through different resistors, imitating the dry powder inhaler. So we had patients, we trained them, and they had to inhale through a resistor of 4 millimeter, 5 millimeter, 6 millimeter, 7 millimeter. So this is a dry powder inhaler with a high resistance, and this with 7 millimeter would imitate a dry powder inhaler with a low resistance. And we just asked them to inhale forcefully. So what you can see is that, first of all patients, they can generate flows, except one, which are higher than 30 liters per minute. And there's an enormous range. So this is, on the left, this would be a slow inhalation, and on the right, 160 liters per minute is an extreme fast inhalation. And on the vertical axis, you see the volume they can inhale. Of course, this is, if you have severe disease, the volume can be impaired. And in fact, you see that there is also, again, a wide distribution. There are patients who can only inhale like half a liter, and other patients who can inhale almost 4 liters. So if you now take the requirements of the tip, the tobramycin inhalation powder, you have to be able to release the porous particles with a flow of 30 liters or higher. And actually, you can see that almost all patients can do that. So the flow the velocity of inhalation is not an issue. On the vertical axis, you see the volume, and actually you see there is about 1/4 of the patient which cannot generate enough volume to empty the capsule in one breath. And actually that's why the instruction of tobramycin inhalation powder is that you have to inhale twice to be sure there is no drug left in the capsule. The other thing you can see is that if you have a device with low resistance, those patients generate higher flows than, of course, if you inhale through a device that has a high resistance. So thinking again about this concentration issue, I was wondering, is the problem not that the patient who are dry powder inhaler inhale very fast and therefore have a high concentration in their central airways? Again, this is the total diameter, the total cross-sectional diameter of all your airways. So is it not the case that these patients have a very high concentration in sputum because most of the drug ends up in central airways, and therefore less drug ends up in the peripheral airways, and therefore, because most disease and Pseudomonas is located there, don't we treat them less effectively? And at that time, I did just kind of back on the envelope calculation, assuming 12 square meters for the total surface area of your airways, and assuming an epithelial lining fluid of 7 micron thick, so therefore calculating 84 ml of total epithelial lining fluid, then coming up with that we had to have a dose of a concentration which should at least be 125 microgram per ml to be effective. And well, on this calculation, it was above, I calculated it was about 300 microgram. Well, that should be enough then if there was a homogeneous deposition, but taking into account that because of the inhalation pattern, that probably most drug ended up in central airways, we wondered whether that was really the case. So we wanted to ask to address the question: what are the concentration in the small airways? What is the impact of breathing pattern, inhaling slowly, inhaling fast? What is the impact of particle size, small particles, big particles, and how does this relate all in relation to structural changes in these patients? So that makes, then we come to the next section, the modeling study that we did to answer these questions. And this was done by Aukje Bos. He's a PhD, was one of my PhDs, published in PLOS ONE. And we wanted to compute small airways concentration of S3 lysine, of the abbreviation OSLI, using a patient-specific lung model through a wide age range, and we wanted to use for that computational functional imaging, or functional respiratory imaging, as it's also sometimes called. We hypothesized that there would be a great variation in OSLI concentrations throughout the airways due to differences in airway geometry and disease severity. And that in the small airways, we assumed actually that the concentrations would be below the effective concentration because of the huge surface area. So how did we do that? We built a model, a computer model, taking the nebulizer mouthpiece, generating the extrathoracic region from anatomy data. We had to program the breathing profile, and we wanted to calculate what would happen depending on the thickness of the epithelial lining fluid. Because in cystic fibrosis, the epithelial lining fluid is thought to be less thick. We want to have patient-specific anatomical data, for therefore we wanted to collect the CTs of patients to generate the intrathoracic region, to reconstruct the bronchial tree, to divide the lungs in lobes. And because our patients get routinely a scan and inspiration and expiration, as I showed you before, we know the delta volume for each lobe. In other words, if you inhale, you know how much air will go to each lobe of, if you talk about inhaled aerosols, you will know the fraction of the inhaled drug where it will go, and you can compute then the concentrations per lobe. For CT scans, you only see airways up to the 7th generation, 1 millimeter, 2 millimeter diameter. And beyond that, the airways are still there, and we use the Phelan model for the smaller airways. So how did we do that? We used for our study the Sophia CFCT cohort. Again, since 1996, we do routinely chest CTs every second year to monitor progression of CF lung disease. And since 2007, we do it parameter controlled. So we have, again, max inspiratory scan at total lung capacity, expiratory scan at residual volume, knowing now the delta volume per for each lobe. So what were the outcome parameters for this study? The regional concentration of the OSLI and calculating the surface area, thickness of the fluid, computing from that the drug concentration, and relating that to the minimal inhibitory concentration. And to be on the safe side, we took 10 times the MIC90. Which is for Pseudomonas. That would be the 1280 microgram per ml. So why this 10 times? Because as soon as you inhale the drug, the lung already starts clearing the drug. So you need an abundance of drug to be sure that over time you will have enough drug. So that's not cleared right away. For the patients, we of course noted demographics. We have the spirometry as an indication of the lung damage, and we also quantified the structural damage on the CT scans using at that time the CFCT scoring system, which gives you an estimate of the severity of bronchiectasis, airway wall thickness, and air trapping for each lobe. So here you have the patient characteristics for the patients: 35% male, mean age 11.4 years, so 6 to 18 years, wide range of spirometry values 70 to 115. Bronchiectasis score varied between no bronchiectasis to 16%, and so on a maximum scale of like 30%. So this would be a patient with quite severe structural damage. Trapped air score also varying between 11 and 85%. So on the figure, you see in the horizontal axis the age, and on vertical axis you see the bronchiectasis score. So again, there is wide age distribution and a quite a distribution in the severity of bronchiectasis. So here I show the model conditions. So we assumed an average weight of like 38 kilos, tidal volume, investigated shallow breathing, which represented 6 ml per kilo tidal volume, or deep breath 14 ml per kilo. Respiratory rate, we varied between 14, quiet breathing, until 22, so that will be like more like exercise. Inspiration expiration ratio 1 to 2. We simulated sinusoidal breathing patterns, so inspiration, expiration. And we tested for various particle size, mean particle size values. Large particles 4.4 micron, median 3.18, small 2.8. And again, we computed concentrations depending on the thickness of the epithelial lining fluid: 7 micron, 5 micron, 3 micron. So to summarize this method, so we have CT images of our patients. We can segment the bronchial tree for each patient, so we have a unique bronchial tree. We clear the images, we subdivide them in lobes to calculate concentrations for each lobe. To do so, you need a computer mesh, so you know you can detect where each particle lands to calculate the local concentration. We had set the model conditions, we connected to the throat and the mouthpiece, and then we can do the computational fluid dynamic modeling. So this shows you the results just of 6 different patients, and these are the images for the worst case scenario, which means thick lining fluid, meaning low concentrations, and the largest diameter of particles, which have a higher probability of landing in the central airways. And this is a color-coded map, meaning we want to have something which is above 10 times the MIC. That would be depicted here as yellow, so as 1 times 10 times the MIC 19. So everything above is good, and everything below would mean a too low concentration. So first of all, what you see in central airways, we get tremendously high concentrations. And this is more than 100 times, 10 times MIC, 1,000-fold MIC. So tons of drugs in the central airways. But having said that, you see that there are also segmental bronchi, which actually get a drug which gets in the region of the 1 times to 10 times MIC 19 over here. And the parenchymal concentrations are showing in the right upper corner of each image. And there you see in green regions which do not get enough drug. So they're below the value of 1, and their concentrations are suboptimal. And you see that for this patient, has also the left upper lobe. This is the right middle lobe, which is a vulnerable lobe in the lungs. And for this patient is almost the whole right lung. So substantial variability between patients and critical concentrations in the small airways for tobramycin. So to summarize these results, concentrations vary widely throughout the bronchial tree. Concentrations are highly patient specific. And on average, the upper lobes which are most affected by disease also get lower concentrations. Center airways, extreme high concentrations. Think again about the results in the sputum from our study that also showed there's very high concentrations. Small airways concentrations for our simulations could be below the 10 times MIC, and concentrations are influenced by breathing pattern and particle size. This was for OSLI. I don't know if I mentioned tobramycin at some point. We also did the simulation for tobramycin. To correct for the suboptimal concentrations, if you would double the dose, then with our simulations, you would get high enough concentrations throughout the bronchial tree for our 40 patients. So now let's move to the real world, what happens in the patient's home. We talk a lot about adherence, that is how many times you actually take your drug. Very little is discussed actually about the competence. How well is a patient able to inhale the drug correctly in the home situation? So Aukje Bos did a study. It's called the Daily Observation of Nebulizer Use and Technique, the DONUT study. And we wanted to see what proportion of patients had actually adequate nebulizer competence at home. And we wanted to compare the number and type of mistakes per device. We have patients with different nebulizers. So is there a difference between the different apparatuses? And to evaluate also the efficacy of our current instructions. And you must know what I'm going to show you is the best case scenario, because I've done 10 years of aerosol research and we are highly focused on the technique. We pay a lot of attention to instructing the patients over and over again. So how this was done, we visited 32 patients at home, 6 to 18 years old, 2 home visits, and the parents were instructed to how to do, like say, a secret video recording. And we used this book with the camera inside it, and this was positioned in front of the patient, at least that the patient was not aware all the time there was a camera pointed at him. Some children, of course, understood what was going on, but we could see from the video recordings actually that they were forgetting very quickly that they were registered. We also handed out to the parents a questionnaire about the cleaning procedures. The video recordings were scored by 3 independent observers in random order. And we had device-specific checklists. Total score for the technique could range between 0 and 100%. And of course, at some point, we gave feedback to the parents and patient about the quality of their inhalation procedure and what they could improve. So to summarize the result, we had 15% was using a Kita Smart Nebulizer, 62% INAP Smart Nebulizer, and the classic just off-the-shelf compressor nebulizer was used by 20%. Overall, patients were pretty competent, so above 90%. But I think what's important is still 1 in 10 patients had complete incorrect use of the nebulizer, which means they were, according to our estimate, they would not get any of the drug in the lungs, and that is, not good news. That 1 in 10 patients is basically wasting time, money, and health because the technique is not correct. So this means we should even do a better job, and I'm sure that in centers where there's less focus on this competence, that these numbers will look less favorable. So the most important mistake that was made was to maintain a closed seal by lips around the mouthpiece. We didn't see any difference between the type of nebulizer. No association between age, gender, lung function level, or the time span between the last inhalation instruction inclusion in the study or duration of inhalation therapy. Here I want to mention, we didn't do the study in adults, but I'm sure that you would see probably similar results. Cleaning was done correctly in about 2/3, but that means in 1/3 was not done correctly. And there's a very old study that we did that 50% of the nebulizers were contaminated with everything you also can find with microorganisms that you also can find in your toilet bowl. Disinfection was incorrect, was correct in more than 2/3. Maintenance, technical maintenance was correct in only 1 in 4 of the nebulizers. So all recommendations were followed only by 10%. So there's a lot of room for improvement over there. So what about this tip, this tobramycin inhalation powder? And of course, that doesn't have a lot of the disadvantages that you have with the nebulizer, but we did a similar study, Jennifer Meerburg, also one of my PhDs, and she also did video recordings at home, uninstructed, video recorded how the patients were inhaling. And there she saw that mistake, which was often made, there was no breath hold of 5 seconds. This is needed after inhalation because you deposit much of the drug. It will sediment out onto the bronchial wall. It's an important part of your efficiency of aerosol delivery. Incomplete expiration before inhalation was also seen in 40%, which means you have to move all the way down to residual volume and then start your slow inhalation of your dry powder. Incorrect position of the inhaler, inadequate seal. You see similar mistakes can be made also with a dry powder inhaler. So, now I don't see my next, okay. So what about the flow velocity? She also measured that using a special device. On the horizontal axis, you see the FEV1, wide range, patient on the left with a severely impaired spirometry of only 30%, and patients who have a normal values. And on the vertical axis, you find peak inspiratory flows. And you see it ranges from 30 all the way up to 110. Think about the study that I showed you previously. This is like a middle kind of resistance device. So there are patients who really inhale maximally with maximal effort through this device. Though now the official instruction for TIP says you should do a slow, quiet inhalation because you only need 30 liters per minute to inhale the drug effectively. So she, as I told you, she recorded the inspiration profiles of this patient uninstructed. So this would be a patient who inhales forcefully, high peak flow, And then, of course, after 2 seconds, he has inhaled his vital capacity. And over here is a patient who has a quiet inhalation. He goes on and on and on, and is around, it starts off 30, but maybe even it's too slow at some point. She also recorded the patient after she instructed them to inhale as fast as possible. And you see now, you don't see anyone who's doing it slowly. This patient has an interrupted kind of inhalation profile. And she also instructed patients to inhale slowly. This was done in random order. And now you see that some patients, you know, like this would be a perfect profile, like 40 liters per minute, and then it goes on and on and on until this patient has inhaled the vital capacity. But even if you instruct a patient, there is still one patient who inhales forcefully. So it's not so easy to inhale the drug slowly, so it has the drug has a high probability of ending up in the small airways. So here we did again the computation fluid dynamic modeling, and using a selection of typical patients from different disease categories. So here you see actually 3 patients, an adolescent, top panel, a female uninstructed patient, a female and a male. These were both adults, and the images show you what happens uninstructed, what happens instructed inhaling fast, what happens instructed inhaling slow, and on the right, these are the flow profiles that were also recorded while the patient was inhaling from a nebulizer. And again, here's the color-coded map, and you see actually depending on the device, whether inhaled dry powder or a nebulizer, that's for this patient actually, you see that very little drug gets in using the dry powder inhaler, while with the nebulizer, at least you get higher concentrations. For this middle panel is the patient inhaling uninstructed and inhaling instructed fast. You see actually you get lower concentrations right upper lobe. So more drug ending up in central airways, less drug for the small airways. And this is the slow inhalation, and you see actually that now you have very high concentrations in the left lung. So the bottom panel basically shows you more or less the same pattern again. Suboptimal concentrations in right upper lobe when inhaling fast, better concentration throughout the lung while inhaling slowly. So this is the overall results. If patients inhaled TIP slowly, they would have higher concentrations relative to uninstructed inhalation and to the inhalation of the dry powder while inhaling fast. There was actually not a significant difference between inhaling the tobramycin slowly and from the nebulizer, which means if the patient is inhaling correctly, yes, the distribution is probably similar to the solution when inhaled through the nebulizer. So let's now move to the final section, which shows you what happens after the drug has landed onto the epithelial lining fluid. So it has made it all the way from the vocal cords down to the small airways. So, but what other aspects are then impacting upon the efficacy of the inhaled antibiotic? And this was done again by Aukje Bos. She did a systematic review at the time, and it's published in 2017. And the questions that we try to answer is what happened to inhaled antibiotics in patients with this cystic fibrosis after deposition? And of course, you can fill in for this for different diseases, but we focus in this case on cystic fibrosis. Is efficacy determined by concentration or the number of molecules per surface area? It's my feeling that actually the number of molecules per surface area is what matter more than the concentration, but I didn't know, so that was the question that we raised. So what is known about the effect of sputum binding for different antibiotics? CF patients can have massive volumes of sputum. So what is the impact on the antibiotic? And if patient has sputum, how can we compensate for that in our dosing? And what is known about degradation for different antibiotics? So she screened 4,500 papers, and excluding duplicates, ended up with more than 2,000, went through the abstract, ended up at the end with 31 studies that were included, that were discussed in more detail. Important to mention is that almost all studies were done in vitro studies, and most studies were focused on tobramycin and on the effect of Pseudomonas. And I just want to summarize that review because it would be quite repetitive just discussing all the items. But the bottom line is there's enormous amount of variables once an antibiotic has reached its target region, because it can bind to the mucus, it can bind to DNA, diffusion can be inhibited by alginate. If there's biofilm formation, you need substantial higher concentrations for a drug to be effective. Salt has a negative impact on the effect of tobramycin and doesn't impair the effect of colistin. Their effect of endotoxin, their effect of proteins, and anaerobic condition is basically not good for any of the inhaled antibiotics. So basically, it's a miracle that you might say, if you read through this, she has a beautiful table where it's all summarized, then it's a miracle that even these antibiotics, inhaled antibiotics, work. So just to summarize quickly what I discussed, I stress the fact that with inhaled antibiotics, we have to cover a huge surface area. In the section on imaging, I showed you that the severity of the lung disease has an enormous impact on the way how the lung is moving and how air is distributed through the lungs. And this has an enormous impact on the distribution of your inhaled aerosol. Sick parts of the lung gets little drug, healthy parts gets more drug. So actually, I think that inhaled antibiotics is more about preserving relatively healthy parts of the lung than it might act on the diseased part of the lung. If we look at the modeling, we know we have to take the severity of lung disease into account when we treat patients. And actually, we did a study also published doubling the concentration of tobramycin. So go for twice daily administration to once daily to see if we would get higher and better concentrations, high enough to be efficacious. So maybe we have to personalize our regimen based on what we see on the CT scan. The observational study showed you that a lot can go wrong in home situation, and nowadays everybody has a smartphone and a camera, and just ask the parents or ask the father or the husband or wife of a patient, just ask to video register what happens in the home situation and make it and bring it to the hospital to allow discussion with the specialized nurses that can go over the technique over and over again to avoid making critical mistakes. And finally, there are a huge number of variabilities once the drug makes it all the way to the target region that can impact on the efficacy of antibiotics. And clearly, those have to be modeled in a much more sophisticated way to understand why in some patients inhaled drug might work to, for example, eradicate Pseudomonas, and why in other patients it doesn't work. So this was my final slide, and I hope you made it all the way through this more than 1 hour presentation. And now I have time to answer questions. I want to give the floor back to Harpal, who hopefully has received some questions. Thank you.
Thank you, Harm. That was a really fascinating presentation. We have received questions, but if anyone else does have any questions they want to ask, please do send them through. and I'll try my best to get through them the time we have left. So Harm, I'm going to start my first question, if you're ready.
Yep, I'm ready.
So you explained that there are many conditions that can reduce efficacy of inhaled antibiotics. It makes me skeptical on their effectiveness. Are there reasons to believe that they work at all?
Yeah, that is. Actually, I was very skeptical that they could work, and I learned from my microbiologist at the time, and it was in the 90s, that once Pseudomonas was present in the lungs, you could not eradicate it. So that's what I believed. And then there was a study where they did an eradication study in young children using tobramycin. I thought, well, you know, in young children, it's even more challenging to get an antibiotic into the small airways of a patient. So I was very skeptical about the chance of that study to succeed, but I was terribly wrong. Actually, the study was stopped halfway because they actually showed that even in young kids, that a month of therapy with inhaled tobramycin would eradicate Pseudomonas. And if you look with a bronchoscope into those lungs, you see always, especially in young children, there's segmental bronchi blocked by mucus. So yeah, it works to eradicate at an early stage, and actually since the 90s that has become also after several studies, but not really. There's not really very hard evidence. There was never a randomized controlled study being done, also because in Denmark they had the habit also of trying to eradicate Pseudomonas. But since we have become more aggressively in the treatment, actually we have gone down from 65% chronic Pseudomonas to now in our patients below 15%. The other thing I want to mention in relation to your question is, so for patients who are chronically infected, you put them on this 1 month on, 1 month off, and you saw the pattern. Yeah, so it does something on your sputum density, it improves your lung function. Yes, so there is proof that it does something, but still patients fail. So why is that? That might be that no drug gets to the target region. And the other thing, I showed you the image where you see those dark regions on the CTs. So I think, okay, a patient fails the therapy, which I can understand looking at the obstruction. What I didn't understand is why then IV therapy works, because the CT scan suggests that the regions which are not ventilated well, but that they're also hypoperfused. But then I remembered, oh yeah, the lungs has two systems. It has the pulmonary circulation, so that is shut off to diseased lung regions, but there's also the bronchial circulation. So the IV therapy works actually through the bronchial circulation. And that's why if a patient fails, we use IV therapy, which is then more effective to treat exacerbations. So yeah, from clinical practice, we see that it works. The same thing is true for bronchiectasis patients, where several studies have now shown you get like a 2 lockstep reduction in density of Pseudomonas.
Thank you. The next question is, are there superior aerosol delivery options for hospital settings?
Well, in the hospital, I've shown you devices which have been relatively well investigated. In the hospital, it's sometimes even more difficult to, if we talk about the patients admitted on the ward, then you will, if I would ask pulmonologists and also the microbiologists, do you know what devices are used to nebulize your inhaled antibiotic? I would guess that most of the people don't know even what device is used. Often it's a disposable, and it comes in with a package together with other disposables, and that's the kind of disposable that that company is delivered to your hospitals. So first of all, you should be aware what device is using. If it's an efficient device or quite a useless device, that is very important. The other important factor is, of course, the way it's cleaned in the hospital. If it is thrown away or reused, how is it cleaned? Does the cleaning affect the efficiency? Thirdly, you have your administration on the intensive care, and there it becomes even more challenging, because I've shown you the route that an aerosol has to overcome when a patient inhales spontaneous. But now you have a patient on a ventilator, and luckily they're like in-circuit ultrasound nebulizers, which don't generate flow, but can generate the aerosol, and that can be pumped into the sick lungs of a patient. But there is a tube is narrow, a tube can be full of mucus, your aerosol can rain out. So the efficiency of aerosol delivery of an intubated patient is really very, very challenging.
Thank you. The next question I have is, what is your view on the use of inhaled antibiotics in hospitalized patients, such as those with HAP or VAP?
With ventilator-associated pneumonia? Okay,
yeah.
or, yeah.
Hospitalized.
Yeah, hospitalized, yeah. So basically, I think I just answered this. What I think is interesting is to treat your problem in two directions. So IV and through aerosol. There are regions which maybe are not perfused very well and still are ventilated, and the regions which are not ventilated but that are perfused. So I advise people to really understand the kind of disease that you try to treat. Is it parenchymal? Is there airway obstruction? Is there a massive amount of mucus? If there's a lot of mucus, the mucus might be a part of the problem, because it makes the patient sick. So you maybe get rid of the mucus. What about pneumonia? Can you treat it? Of course, there are studies done, but the greatest variable, I think, is the delivery device. So personalize your treatment, understand the disease, go and listen to your patient, put your stethoscope, listen to whether it's mucus, yes or no, how is the ventilation, is there still ventilation? Is it, if you have a COPD patients with hardly any ventilation, maybe you then use your aerosol just to preserve what I said, the very vital, very important last part of normal lung. So personalize your treatment, understand the kind of patient. Again, I think I mentioned, but before I call in a patient in my outpatient clinic, I look at the longitudinal follow-up of spirometry, but I always look at their CT scan to understand the kind of structural damage that I'm dealing with. Clinical studies like the one I showed you shows what on average happens with the patient. And you still have to translate your randomized control trial to the individual. And especially for hospitalized patients, I think it comes back to often expert opinion. Really understand your patient, use all the information you can get, and decide upon the best strategy, evaluate your strategy. Doesn't it work? Maybe change the strategy. So for cystic fibrosis, we now, based again on also the CT scan, and we will now sometimes decide to use an IV and aerosolized antibiotic to target the diseased areas from two directions.
Thank you. Given the delivery issues that you've mentioned, isn't systemic delivery preferred?
Well, every textbook will tell you that an advantage of aerosolized medication is you get very high concentrations. I think I showed you now that is not the whole truth. that is a simplification of what happens. It's actually a whole distribution of concentration throughout the lungs. And you will have regions where you undertreat the lung. And that's interesting because that means if you can't get high enough concentration throughout the lung, then you, of course, well, at least what I learned is that you risk development of resistance. I think again, for IV treatment, it must be the same, because for IV, it's difficult to get high enough concentrations to penetrate into the mucus, into the junk inside consolidated regions of the lung. So again, understand the patient you have in front of you, and evaluate your treatment, and if not successful, then think about maybe this presentation and change your strategy, move from one to the other.
Okay, next question. I'm just trying to filter through. There's a lot coming through now. Are polymeric antibiotics suitable for lung infection when they are administered through nebulizer?
Say that again.
Are polymeric antibiotics suitable for lung infection when they are administered through a nebulizer?
I didn't understand the first part of your question. Is that do you mean there are drugs which are developed for nebulization, and there are drugs which have not been developed for nebulization? Is that what you mean?
Yeah, so not developed.
Yeah, so basically in the past of cystic fibrosis, everything that was a fluid and an antibiotic was nebulized. And for example, I was involved at the time for colistin is actually a mixture of drugs, and if you would now try to register colistin, it would not be acceptable for regulatory. And at the time of pathogenesis, they wanted to purify the active components. That was the E1 component that they focused on, and they did animal tox studies, and actually they asked me to evaluate the histology, and I was shocked by the kind of inflammatory changes that I saw. So you have to keep in mind that a drug might be an antibiotic, but can also be a toxic. It might also have a toxic component, and the balance between the two should be that, of course, the efficacy of the antibiotic should be much stronger than the toxic effect. Tobramycin, for example, is quite an irritant. And Astrinam for inhalation, there was a patient who was absolutely non-compliant, and then he was near transplant, and then Astrinam came on the market, and I got him on compassionate use program, and it was a 3 times daily nebulization, and he improved tremendously. So I asked him, explain me, you never were compliant, and now you improve. How does it come? He said, yeah, the tobramycin tastes horrible, and Astrinam doesn't have a foul taste, and it doesn't make me cough all the time. So yeah, you have to stick to drugs that at least have been investigated properly, unless you're, of course, in a desperate situation. Then you can move to off-label use, but I cannot recommend that. Does that answer your question?
Yeah, it does. Any insights about if and how inhaled drugs could work to treat COVID-19? Be a topical question right now.
Well, for COVID-19, of course, everybody is intrigued by this sudden worsening of patients. And as a pulmonologist, there are actually now, I think, 3 explanations, or maybe more. The CTs I saw reminds me of the distribution of inhalation. The way the Netherlands, at least, the pandemic's developing, it was through patients of people who went on winter sport and were in cabins probably locked in for 15 minutes with patients throwing out a lot of viruses. So I saw a lot of CTs with a lot of hotspots, and there are other patients who just had a few spots. So I think in terms of inhaling your virus, it must make a difference if you get a big load, is distributed throughout your lungs, and that your immune system is running behind the multiplication of the virus. And maybe can only respond with a massive inflammatory response. So that's one thing I learned. The other thing is I thought, oh, it must be super infection in a lot of patients. And actually we're going to look into the images of large number of COVID-19 to see whether we can have from the CT scan have a kind of predictor. For what I saw in terms of the severely ill patients is that they're, especially if it's virus all over the place, you cannot, with inhaled antibiotics will not do anything. If there is like massive consolidation, I don't think that inhaled antibiotics will be of great help. But again, I've been wrong in my hypothesis many times. So if you're desperate, I would say give it a try.
Thank you for that, Harm. I think we've reached the end of the questions section, and I'll hand over back to Astrid now, who can finish off the rest of the session.
All right, thank you, Harm and Harpal. So I just want to note that we have received an exceptional number of questions today. So I'm sure many people in the audience did not get the responses for now, but we will work with our speaker Harm to potentially provide some responses to you in the coming weeks per email. But of course, please be understanding that this may take some time, because of course Harm is volunteering for this presentation, and this will probably be quite time consuming. So but we will do our best. Sorry, I should have thanked you in more detail. So both of you, Harm, thank you for your presentation, and thank you for Harpal for moderating.
Oh, thank you for organizing this all.
That's our pleasure. So I would now like to take the opportunity to announce very quickly our upcoming webinars. We have several webinars at the moment, which are already open for registration on our website, revive.gartp.org webinars/webinars. In May, we will have a webinar about probability of target attainment analysis for dose selection with Shampa Das from the University of Liverpool, as well as a collaborative webinar with the Pew Trusts on the topic of assay development for measuring antibiotic accumulation in gram-negative bacteria. In June, we will have a webinar about PK/PD of fixed-dose BL-BLI combinations with Vincent Tam from the University of Houston College of Pharmacy, followed by a webinar about phase 1 development of antimicrobials with Markus Zeitlinger from the Medical University of Vienna. And finally, in July, we will have a webinar about the challenges and opportunities for antimicrobial R&D in low and middle income countries with Anand Kumar from Bugworks and Kamini Valia from the Indian Council of Medical Research. As I said, you can already register for all webinars. That's all from my side. I would like to thank everybody for joining today and for contributing to the discussion. I really hope you found the webinar interesting and useful, and that you will join for the next webinars. And also make sure to spread the word in your networks, encourage the colleagues to join as well. Thank you and goodbye, everybody.